Epistaxis or nosebleeds are a common problem, and it occurs due to rupture of blood vessels in nasal mucosa. It is commonly seen in children between the ages of 3 and 8, and then decline in incidency after puberty. They are also more common during winter, when cold, dry air irritates the nasal membranes. Treatment depends on the location and the cause of the bleeding. We classify epistaxis into two. Those are the anterior and the posterior one. The anterior epistaxis is from the Kisselbach's plexus area. It is more common and it occurs in children and young adults, and usually due to mucosal dryness, and it is less severe. Whereas the posterior one is from sphenopalatine artery rupture. It is less common, but it is more severe. It is more common in older population and hypertensive patients. As I have said, the most common site of bleeding is the Kisselbach's plexus or the anterior bleeding, which is responsible for 90%. But the most severe is the posterior bleeding, but responsible for lesser amount, around 10%. The Kisselbach's plexus is area where vessels from both the internal carotid and the external carotid converges. The thin mucosa in this area, as well as the anterior location, makes it prone to exposure to dry air and the trauma. So as I have said, based on the site, we can classify as anterior and the posterior, whereas based on the cause, we can classify nosebleed or epistaxis as primary and secondary. Primary is unknown cause or idiopathic, and the majority of cases is primary epistaxis, whereas secondary cause is when we know the etiology for epistaxis, and this has implication for diagnosis and also management. Common cause of secondary nosebleeds from the anterior septum include: the most common one is digital trauma, then followed by foreign bodies, dry air, inflammation, including upper respiratory tract infection, sinusitis, and allergic rhinitis. Susceptibility is increased during respiratory infections and in the winter when dry air irritates the nasal mucosa, resulting in formation of fissures and crusting. Severe bleeding might be encountered with congenital vascular abnormalities such as hereditary hemorrhagic telangiectasia, varicositis, and hemangioma. In children, nosebleeds can also occur from thrombocytopenia, deficiency of clotting factors including von Willebrand's disease, and nasal polyps or other intranasal growths might be associated with epistaxis. Nasal polyps, if it is bilateral and if it is a huge amount and a long standing, it might be a suggestive feature of cystic fibrosis. Recurrent and often severe unilateral nosebleeds might be the initial presenting symptoms in juvenile nasal angiofibroma. This occurs in adolescent males mainly. As a summary, the cause of epistaxis can be classified as traumatic, tumoral lesion, infectious cause, and a disorder of hemostasis. The most common cause of epistaxis in children is most of the time traumatic. And also infectious cause is responsible for a lot of epistaxis in children. But tumor and the disorder of hemostasis is a less common cause of bleeding or epistaxis in children. Epistaxis usually occurs without warning, with blood flowing slowly but freely from one nostril or occasionally from both. In children with nasal lesions, bleeding might follow physical exercise. When bleeding occurs at night, the blood might be swallowed and become apparent only when the child vomits or passes blood in the stools. As you know, blood is a cathartic and iron is a constipating drug. So when a child swallows a blood, it causes nausea and vomiting. So they might vomit the blood due to swallowing of epistaxis. Posterior epistaxis can manifest as anterior nasal bleeding, or if bleeding is copious, the patient might vomit blood as the initial symptom. So always we should have to ask the history of epistaxis or nosebleeds when a child comes with a complaint of bloody vomiting or upper GI bleeding. Regarding treatment, most nosebleeds stop spontaneously in a few minutes. The nurse should be compressed and the child kept as quiet as possible in upright position with the head tilted forward to avoid blood trickling back into the throat. Cold compresses applied to the nose can also help. Local application of a solution of oxymetazoline or phenylephrine might be used. If bleeding persists, an anterior nasal pack may be inserted. And if bleeding originates in the posterior nasal cavity, combined anterior and posterior packing is necessary. Use nasal saline sprays or lubricants to keep inside of the nose moist. Avoid smoking. Don't pick your nose too often as well as don't blow it too hard. Steam inhalation can moisten and protect the nasal cavity as well as reduce nasal irritation. This is a preventive test for nosebleeds during summer. Secondary epistaxis should be managed by identification of the cause, application of appropriate nasal therapy, and correct systemic medical management. Hematologic evaluations for coagulopathy and anemia along with nasal endoscopy and diagnostic imaging might be needed to make a definitive diagnosis in case of severe recurrent epistaxis. Replacement of deficient clotting factors might be required for patients who have underlying hematologic disorders. Regarding prevention, the discouragement of nose picking and attention to proper humidification of the bedroom during dry winter months help prevent many nosebleeds. Prompt attention to nasal infection and allergies is beneficial to nasal hygiene. Prompt cessation of nasal steroid sprays prevent ongoing. This is all about epistaxis. Thank you for listening.